5, 4, 3, 2, 1.
Good afternoon, good evening, ladies and gentlemen, friends and colleagues. My name is J.K. Lee. I am an orthopedic surgeon from Malaysia. It is our greatest honor for our APOFFS Asia Pacific Osteoporosis and Fragility Fracture Society, a new section of APOA formed last year. And it's really our honor to have all of you join us on the different platform and to actually enjoy our first webinar of APOFFS. And it's also our greatest honor to have all our faculty members and some of our council members as well. And our first webinar will be run by our own council members today. And we have 5 very important and prominent speakers from different countries with different specialties. So it's really honored to have all of us here in this group. And so to kickstart, I'd like to introduce the 5 important names: Professor Shahidul Islam from Bangladesh, Dr. Runner Wong from Hong Kong, and Dr. Zairin Noor Helmi from Indonesia, and Dr. Rajesh, I think everybody knows Rajesh, Malhotra from India, and Irewin Tabu from Philippines, a good friend of mine in other society as well. So I think our talks today, we mainly focus on osteoporosis and related fractures at different parts, and hopefully give you an idea the importance of the osteoporosis as well as fragile fractures and fall prevention and all the whole pictures on fragile fracture care. So without further ado, I would like to invite Prof. Syedul Islam from Bangladesh to give his first talk on the burden of osteoporosis and fragile fractures. Prof. Syed, the floor is yours. You can share the screen now.
Can you see my slide?
Yes, Prof. Syed.
It's okay?
Yes, good to go. Prof. Syed, clear.
Thank you, Mr. President, the chairperson today, J.K. Lee, for inviting me for this webinar. I am Dr. Shahidul Islam from Bangladesh. The topic of my presentation is the burden of osteoporosis and fragility fracture. This is my working place, Evercare Hospital, Dhaka. All of you know what is osteoporosis, and the main problem of osteoporosis is weak bone that breaks easily and increase the risk of fractures. And this is called fragility fractures, the fracture that results from mechanical forces that would not ordinarily result in a fracture. In other words, the fracture that occurs from a fall from a standing height or less, or if someone lifts something of light weight and sustain a fracture. Using the data of World Health Organizations, Keynes et al. Published in 2008 that 6.3% of men and 2.1% of women over the age of 50 globally has osteoporosis. And based on the world populations, the total 500 million men and women worldwide may be affected with osteoporosis. This is the just published data by Keynes et al. In the Archive of Osteoporosis. This is the project of scope by International Osteoporosis Foundations, a 25.5 a 25.5 million women and 6.5 million men, a total 32 million people are affected with osteoporosis in Europe. And in Asia, there is no exact data from the different countries due to prevalence of osteoporosis, because in many countries they don't have data, and also in some countries, highly populated countries like China and India, 60% people lives in the rural area where there is less facilities of diagnosis of osteoporosis. But you can see here the Asia Pacific Audit, and they're giving the Epidemiology and Burden of Osteoporosis in 2013. And they said that overall populations will grow up 24% between 2013 to 2050. And you see here, the percentage of population over 50 years or over from 2013 to 2050 will 144%. So they assume that from the 71 Asian Pacific countries, 119 million people aged 50 years and over are projected to be at high risk of fracture by 2040. It is published in 2006 by Canis in 2050 that 1 in 3 female and 1 in 5 male aged over 50 years will suffer an osteoporotic fractures, and about 8.9 million fractures annually, that is 1 fracture every 3 seconds. And these fractures, 51% from Europe and America and 49% from Western Pacific and Southeast Asia. And they calculated that only the hip fracture increased from 1990 to 2020.
Sorry, ladies and gentlemen. I think there's some technical glitch here, most likely because of the signal. And the team, yes, I think the Prof Syed trying to connect in again.
Yeah, we can wait for him to connect back.
Sure. Prof Syed, you're muted.
Can you see me now?
Yes.
Yes, sorry. So I have to go the screen share again.
Sure.
So now, which one is?
Yes, can see now. Clear.
This clear. So I have to go. I have opened 2.1. This is.
Yeah, Prof Syed, you can go ahead. Yes.
Okay. This is the last slide. That approximately 55.3 billion euro has been spent in Europe during 2019. And you can see here in the bottom that about 4.3 million fragility fractures in 2019 in Europe, and 5.34 million will be in 2034. That is an annual increase of 24.8 million. 24.8%. And among the new fragility fractures, hip fractures, vertebral fractures, and forearm fractures constitute 50%, and the other fractures also 50%. So you should consider the other fractures also. But in America, where from the 10 million Americans of osteoporosis, there is 2 million fractures every year, and there is a 60% of fracture involving the vertebral, wrist, and hip fractures. And their direct cost was 17 billion. But in fragility fracture burden in Asia Pacific, there is no specific data. I have said already, there is 319 million people aged 50 years from Asia Pacific are projected to be at a high risk of fragility fracture by 2040. And about 50% of all fractures in the world will occur in Asia by 2050. You see here, this is a 20 years back published this data that risk of subsequent fractures after initial vertebral fracture. You see clinical vertebral fracture, there is risk about 12-fold, and hip fracture more than 2-fold, and distal forearm fractures 1.6-fold, and also there is a chance of pelvis fracture, clavicular, sternum, and rib fractures. And the same publishers in 1919, they published this data also that after 1 year of having a index fracture, 20% chance of fracture within 1 year of men and female, and male has 17.5% chance of fracture within 1 year. And a prior fracture is associated with 86% increase in another fracture. So this is very important slide just published. The treatment gap in European countries in 2019. You can see, despite the all availability of screening, diagnosis, and treatment facilities in Europe, many countries have very high moderate treatment gap. That is about 80% of people who have had at least one osteoporotic fractures are neither identified nor treated for osteoporosis. And in other words, from the vertebral fractures, only 2/3 of the fractures are not coming to us for clinical attention. Only 1/3 is coming to the clinician for their treatment. And treatment gaps in osteoporosis, these are the contributors of the treatment gap osteoporosis regarding the case finding and management, public awareness, and government and healthcare system issues. Most important is that despite the all facilities in Europe, you see there secondary fracture prevention is gap is the very important gap. The National Osteoporosis Foundation published this that the time is now to diagnose and treat this silent killer responsible for 2 million fractures in America, cost about 52 billion in 2018. And the expert predict that the osteoporosis will be responsible for over 3.2 million fractures annually over the next 22 years within 2040. And the cost will be increased from 52 billion to 87 billion. And already I have said previously that there is a 56.9 billion cost in Europe. And if you consider in Asia, only Asia, hip fracture, it is 9.5 billion in 2018 and will be increased 15 billion in 2050. So you see here, the fragility fracture is a disability burden in Europe, after the ischemic heart disease being the first and fragility fractures being the fourth disability in Europe among the non-communicable disease. And this is very important slide to me. This also published in 2020 that lifetime risk of fragility fracture from the age of 50 years equivalent to lifetime risk of cardiovascular disease in these 6 European countries like France, Germany, Italy, Spain, Sweden, and United Kingdom. And in other side, only the lifetime risk of only hip fracture from the age of 50 years, it is the equivalent risk of stroke in Europe. So it is published in 2002 by Canis, and then said the combined lifetime risk for fragility fracture is 40%, which is equivalent to the risk for the cardiovascular disease. This is important slide also to me. This is published by American Society for Bone and Mineral Research. And they say the annual hip fracture in America is 258,000. Heart attack is huge, 720,000, and the invasive breast cancer is 230,000. But I am interested in this slide that only 10% of the individuals having heart attack usually die within 1 year. That is 1 year mortality 10%. You can see in breast cancer, 1 year mortality is 20%, but in hip fracture, 1 year mortality is 25%. If we calculate from this, the annual death due to heart attack is 72,000, and breast cancer 46,000, and in hip fracture, only hip fracture, some portion of burden of osteoporosis is 64,000. This is another slide you can see here. The lifetime risk of a fracture of a 50-year-old lady have 50%. In other hand, breast cancer is only 12%. So there are many awareness programs, many screening program, and many treatment programs for heart attack and breast cancer. But sincerely speaking, there is little program, especially there is no program in Asia for hip fracture, for the assessment of hip fractures and other fragility fractures. So I want to draw attention of this learned participant in this slide. This is a burden. This is published in 2007 and 2018 by the Journal of Bone and Mineral Research, American Heart Association, and American Cancer Society. If you calculate the incidence of annual incidence of breast cancer, stroke, heart attack, this is less than 1 million. But osteoporotic fracture in America is 2 million annually. So this is a huge burden of osteoporosis and fragility fracture. The orthopedic surgeons are trying their best and giving the most modern treatments for the hip fractures. But the story is not end here. You can see this post-operative good-looking X-ray. But the history, other history is 25% will die after first year of hip fracture, despite the giving up all modern treatment. And profound loss of function, including 40% unable to work independently, 60% require assistance, and 10 to 20 or up to 30% require long-term nursing care, and they remain in nursing home and unable to return back to their home. And there is a double risk of sustaining another fractures. And the same thing is in case of spine fracture. Most common fractures, and one fracture occurs in every 22 seconds, occur during normal day-to-day life activities, and even in 30% of vertebral compression fractures occur while the patient is in bed. And a 50-year woman has a 16% lifetime risk of fractures, and 2/3 of the fractures are not clinically recognized. So spine fragility fractures significance lead to back pain, deformities, loss of height, poor mobility, reduced respiratory functions, distorted body image, and depressions of the patient, and associated with 8-fold increase in mortality and a 1 in 4 chance of another fracture during next 5 years. So my take-home message is, recognize the burden of osteoporosis and fragility fractures. There is the increased rate of fragility fractures in every year, and there is a high rate of recurrent fractures also. The fractures are associated with profound functional loss and mortality risk, and timely screening, treatment, and fracture prevention is important. Sincerely speaking, current practice of screening, treatment, and fracture preventions are not sufficient. Love your bone, protect your futures. Thanks for patient hearing, and you are welcome for any questions and comments. Thank you very much, Mr. Lee. Can I stop my sharing? It's okay?
Yes, sir.
Can you hear me?
Yeah.
Yep. I think you lost me for a short while just now. Prof. Syed, thank you very much for the talk. And you have highlighted very strongly to all of us, particularly our orthopedic colleagues, friends, our community, important to understand and realize that the tsunami of fragility fracture related osteoporosis is there. The issue is whether should we actually, how do we actually raise awareness among our orthopedic colleagues, and also how to reach out to the public, and also the policy, the healthcare professional, the policymakers to raise awareness. So we still have some time for you, Prof. Syed, some questions. And the first one I'd like to ask you is that how to actually convey the message to ground zero, where the public awareness and about osteoporosis, and not only that, about the importance of fragility fractures. What is your view on that? Syed, to reach out to public.
Thank you, Lynn. Especially, we have to organize some this webinar, and we have to use our both electronics and print medias among our own countries to for the awareness of the public. And we have to involve the leaders of the community, including especially in our country, the political leaders as well as the community leaders about the burden of osteoporosis and consequence of osteoporosis and fragility fractures. Like I have already said, the hip fracture, after having a hip fracture, the patient, 25% patient dies within 1 year. And maximum patient is unable to return back to their own life again. So we have to use this media, and we have to place our proposal to our government level, political leaders level, that the government can take the screening program and awareness program for this burden of osteoporosis and fragility fracture.
Okay. And the other thing is the approach. For many years, we talk about osteoporosis and osteoporosis and osteoporosis, and a lot of public, even our family physician, primary care, get a bit fed up with the topic there. But do you think the approach from the other way, we actually tell them more about fragility fractures, let them know the consequences of osteoporosis, and from that approach, to raise the awareness, the fear of getting fragile fracture when they are old, and so that will be a better approach rather than osteoporosis and they don't see the final impact.
Yes, of course. Yes. Dr. Rajesh is also giving consent to your approach. Yes, we should give the information to our community regarding the consequence of fragility fractures. I have said in my first slide that we have osteoporosis, no problem. Osteoporosis is not a problem. The fracture is the culprit. This is the problem, and this fracture causing this disability and mortality.
Okay. And Rajesh, I give 1 minute. Any input from your side, Rajesh?
So you are absolutely right, because osteoporosis we call is a silent killer. It doesn't cause any problem. So people don't convinced about taking any treatment for something which is not bothering them. So I think it's very important to reiterate and emphasize, and we do that to relatives of all patients who have the osteoporotic fracture, that see, this is what happens. And if you are family, there's a genetic predisposition also. So I think we have to do it at every level, community, patient to patient, and clinic, everywhere.
Sure. Thanks, Rajesh. And Rajesh is also the president-elect of our APOFFS. Thanks, Rajesh. And thanks, Syed, for your talk and also the emphasis that, that you informed to everyone, the tsunami. We are facing a tsunami, particularly in Asia Pacific region. Thanks, Syed.
Yes.
So without further ado, and the next speaker is actually Dr. Runner Wong from Hong Kong. I think one of the issues that all our orthopedic colleagues face is that, and all our usual practice is that we see a fracture, we fix the fractures. And then after that, the treatment, well, yes or no. If yes, then send the patient over to a physician, geriatrician, continue treatment. And from there, you can see a lot of them actually just leave you and you don't see them anymore until they come back with the second fractures. And many of us find that as a surgeon, we might not have the interest to actually know more about pharmacological treatment, treat the underlying osteoporosis. So that's the whole purpose of the next talk, where Ronald is going to emphasize, as an orthopedic surgeon, what is our role to actually promote treatment, pharmacological treatment, even as an orthopedic surgeon, that we should be confident, we should be taking the initiative to treat them even before they get discharged from the hospital. So without further ado, Ronald, the floor is yours to talk about different options, treatment options for osteoporosis. Yes, Ronald.
Yep. First of all, I'd like to thank the APOFFS and JK for allowing me to present in this webinar. I've been asked to discuss on the topic of treatment options for osteoporosis. Now, I'm an orthopedic surgeon practicing at the Prince of Wales Hospital, the Chinese University of Hong Kong, And a lot of day in, day out cases are fragility fracture patients for me. As a trauma surgeon, besides from performing operations, I also believe that preventing the second one is also very important. And today I'd like to share my views from a surgeon's perspective. Now, with the aging population amongst the orthopedics community, we're faced with a lot of challenges. Not only do fragility fractures sometimes lead to difficulty in fracture fixation, but also medically, we need to make decisions to best treat our patients. Most of us use the WHO guidelines for osteoporosis, but it's also important to remind ourselves that once there is a fragility fracture, we tend to already offer the patient with treatment for osteoporosis due to the high risk of another imminent fracture. But the question is, how is it best to approach the case and subsequent management? Now, take this case example of Miss X. She's an 81-year-old lady with history of hypertension and diabetes, pre-morbid, a stick walker. She accidentally slipped and fell, landing on her buttock, complaining of hip pain, and was unable to weight bear. So as you can see, this is a very typical history of a hip fracture. And today I'd like to go through the process and how I would manage the fragility fracture patient. Now, this is the AP X-ray of the patient's pelvis, including proximal femurs. As we can see, there's a displaced left side neck of femur fracture with a broken Shenton's line. A lot of us see hip fracture cases on a daily basis, but a bone health treatment afterwards was often suboptimal in the past. We performed a cemented hemiarthroplasty for our patients, and the purpose of the surgery, as we all know, is for pain relief and to improve the mobility. So now, what after surgery? In fact, there are more than 6,000 hip fractures every year here in Hong Kong, and in order to improve the situation, myself and my team established guidelines in Hong Kong for the promotion and establishment of fracture liaison services in all hospitals to coordinate the management of these patients. We published this article in Hong Kong Medical Journal as a reference and standard for the management of fractures here. And as a result, now all our hip fracture patients in our unit receive the geriatric co-care, and most hospitals have also adopted fracture liaison services together with a specialized nurse coordinator. And I'm sure we all understand the importance in treating bone health, but what drugs would you use to manage your patients? Now, some common drugs that we often use in the fracture setting in our location are namely anti-resorptive drugs, including bisphosphonates and denosumab, and anabolic agents, including teriparatide and romosozumab. It's important to note that osteoporosis typically requires long-term treatment because we do not yet have a cure. And so often we need different treatments at different time points to best manage our patients. Skeletal integrity is maintained through a balance of bone resorption and bone formation. And each anti-osteoporotic drug have different mechanisms and side effects. An optimal therapy may require various sequences. But given a choice of drugs, how should we choose amongst these drugs? Now, it's well known that there are many risk factors for fragility fractures, but in an orthopedic setting, we often already encounter the first fragility fracture, and there has been increasing evidence that the recency of a fracture or the imminent fracture risk is even more important. So what's the evidence that we have that a recent fracture leads to a high risk of an imminent risk of fracture? Now, a recently published article in Archives of Osteoporosis also highlights the concept of imminent fractures, which are fractures that occur within 2 years of an initial one. And consistent with literature, we found that a large percentage of secondary fractures actually occur during this period. Therefore, this window of opportunity is also the most effective in the prevention of a secondary fragility fracture. A post-hoc analysis has also shown that male patients are at even higher risk. Clinicians and allied healthcare professionals should be alert on these patients. And based on this, our fracture liaison services target this 2-year period in particular. And based on our strategies, we show that prompt osteoporosis treatment and fracture liaison service coordination allows us to reduce imminent fracture rate to only 0.4% in our published study. This highlights the importance of fracture liaison service and hopefully will serve as a platform to improve solutions. So how does a recent fracture actually affect our clinical management? Well, there are numerous guidelines that have come up recently, including the American Association of Clinical Endocrinologists, American College of Endocrinology Practice Guidelines, and the IOF guidelines. Now, both guidelines present different findings, but one of the key points to treatment is actually categorize the risk of your patients. Now, take a look at how categorize the very high-risk patients. For the IOF guidelines, a recent clinical vertebral fracture, a previous fracture of age 80 years old or above, or a previous fracture and family history of a hip fracture would be considered very high risk. As for the AACE guidelines, again, a recent fracture or a fracture whilst on approved therapy, multiple fractures, very low T-score, or very high fracture risk by FRAX would be considered very high risk. Note that although both the IOF guidelines and the AACE guidelines have slightly different recommendations, a recent fragility fracture would be considered very high risk. I take the AACE 2020 guidelines as my reference, and for my hip fracture cases, I would classify them into very high risk with a recent fragility fracture. As you recall from our previous slides, the imminent fracture risk is actually very high for these patients, leading to this very high risk. And so this window of opportunity is also a golden period for prevention. And for these very high-risk patients, it's now been recommended that we should consider using bone-forming drugs followed by an anti-resorptive drug as sequential therapy, as there's currently convincing evidence that it is clearly effective not only in preventing bone loss, but also further increases hip and spine bone mineral density. Now, most anabolic agents are limited to 12 to 24 months, and the efficacy will wane once treatment is stopped. But the real potential of the anabolic treatment is that their greater effects on BMD and fracture can be maintained with anti-remodeling drugs. Now, in patients at very high risk of fracture, such as a recent fragility fracture, starting treatment with an anabolic agent seems most appropriately to promptly reduce the fracture risk, as they have greater effects on BMD and reduction of fracture risk. Furthermore, numerous trials have also shown that anabolic drugs are superior to oral bisphosphonates and have faster increase in BMD. I'll be covering a few landmark trials to show how anabolic drugs have been found to be superior. And here are some of the evidence. Look at a Vero trial where participants were randomly assigned to receive either teriparatide and oral placebo or oral risedronate with injection placebo for 24 months. At 24 months, new vertebral fractures occurred in 5.4% in the teriparatide group compared to 12% in the risedronate group. Clinical fractures also occur in 4.8% in teriparatide group compared to 9.8% in the risedronate group. And so amongst postmenopausal women with severe osteoporosis, the risk of new vertebral and clinical fractures is significantly lower in patients receiving teriparatide, demonstrating its superiority. Another landmark trial would be the ARCH study. In this study, postmenopausal women with osteoporosis and a fragility fracture were randomly assigned to receive either romosozumab or weekly oral alendronate for 12 months, followed by alendronate in both groups. I'll be covering more of the results later in our slides, but in this study, results show that at 12 months' time, romosozumab had a significantly lower number of new vertebral and clinical fractures as compared to alendronate, again demonstrating the superiority of bone-forming agents compared to oral bisphosphonates. Now, given that treatments of anabolic agents are limited to 12 to 24 months and that efficacy will wane once treatment is stopped, the real potential is that the greater effects on BMD and fracture can be maintained with anti-resorptive drugs once stopped. There's now convincing evidence that after switching treatment, sequential therapy further increases BMD. So for Miss Y, she was mobilized the next day by our physiotherapist, and DEXA of the lumbar spine came back to be negative free, and she was given a bone-forming agent. And here is some of the evidence showing sequential therapy further increases bone mineral density on reducing fractures. Now, if we look into the data switch study, this was a 24-month study in which postmenopausal osteoporotic women were randomized to receive teriparatide, denosumab, or both drugs. In the extension trial, women originally assigned to teriparatide further received 24 months of denosumab. whereas subjects originally randomized to 24 months of denosumab further received 24 months of teriparatide. In fact, after 48 months' time, spine BMD increases the most in teriparatide to denosumab group compared to the others. For the total hip bone and femoral neck bone mineral density, this was also increased more in the teriparatide to denosumab group compared to the denosumab to teriparatide group. This also clearly demonstrates a successful sequential treatment. Coming back to the ARCH study, results over the whole period of the 24 months showed a 48% lower risk of new vertebral fractures in a romosozumab to alendronate group compared to the alendronate to alendronate group. The risk of hip fractures was also lower by 38%. In postmenopausal women with osteoporosis who are at high risk for fracture, romosozumab treatment for 12 months followed by alendronate results in significantly lower risk of fractures than alendronate alone. Again, this demonstrates the success of sequential therapy from anabolic agents to anti-resorptive drugs. Looking into the FRAME study, postmenopausal women with osteoporosis were randomly assigned to receive romosozumab or placebo for 12 months. After that, patients in each group received denosumab for 12 months. At 24 months' time, the rates of vertebral fractures were significantly lower in the romosozumab group than in the placebo group after each group made the transition to denosumab with a 75% lower risk. This study again illustrates the success of sequential therapy. Now, it's not uncommon where a patient comes in with a fragility fracture that was on previous bisphosphonate therapy in an orthopedic setting. But how should we treat these patients? For me, as this is a recent fragility fracture, and also there was an occurrence of a fracture despite treatment, I would again categorize these patients as very high risk. Now, as we all recall, in these cases, we would have to consider the use of anabolic drugs to best increase the bone mineral density and reduce the fracture risk. The question is, which anabolic drug should we use now? Now, the Structures trial aims to answer this question by comparing the effects of 12 months of romosozumab versus teriparatide on BMD in women with postmenopausal osteoporosis who had previously taken oral bisphosphonate for at least 3 years and also had a BMD T-score of -2.5 or lower and with a history of fracture. Patients were randomized to assign to romosozumab or teriparatide, where the primary endpoint was the percentage change from baseline in aerial BMD in the hip through 12 months. And it turns out that the mean percentage change from baseline in total hip BMD was 2.6% in a romosozumab group and -0.6% in the teriparatide group. Now, transitioning to a bone-forming agent is common practice in patients treated with bisphosphonates, such as those who fracture whilst on therapy. And in these patients, romosozumab leads to gains in hip BMD that are not observed with teriparatide. And so we may need to consider the use of romosozumab, which has dual effects by increasing bone formation and decreasing bone resorption when we decide on transition from bisphosphonates. Now, besides on bone health, a published systematic review had shown that sarcopenia can also occur in up to 95% in males and 68% in females with fragility fractures. And in these patients, based on this reinforces that fracture services should also focus on muscle health as well. There's currently a pressing need for further research on sarcopenia. And for our patients, we advise and refer them to do exercises as well as nutrition. Going back to Miss Y, she was also diagnosed with sarcopenia. Physiotherapy was referred for walking and resistance exercises, and dietitian was also referred. Supplements of calcium and vitamin D were also given. It was fortunate that during her follow-up for 2 years, there was no further falls or fractures. She was then treated via sequential therapy with an anti-resorptive agent, and she was able to walk with a stick independently as well. So as a summary of the management at my unit, each fracture patient is thoroughly evaluated. In patients, we have an orthogeriatric co-care. The patient is also referred to the dietitian and physiotherapy for rehab. Now, as a recent fragility fracture is considered very high risk, preferably a bone-forming agent is used. But in a public setting, The patient is covered only if they have a history of 2 or more fragility fractures and a very low T-score. So in general, zoledronic acid or denosumab is used. The DEXA scan is offered for all our hip fracture patients. Upon prescribing the drug, the patient is monitored with DEXA every 2 years. As for the targeted the treatment target would be at least more than -2 and preferably to -1.5. And if the T-score was greater than -2.5 to begin with, I would go for at least 1.0 T-score unit improvement. Once target is reached, if the patient started off with an anabolic drug, sequential therapy would be offered. And if the patient have reached the target with bisphosphonates, they would go for a drug holiday. And for those that have reached treatment target with denosumab, they would either continue or switch to a bisphosphonate. With that, I'd like to thank the audience, and I hope my sharing was useful.
Thank you very much, Ronald. I believe all of us agree with me that there's a very important, powerful synopsis that we have done for all of us and make us understand what are the treatment options, the pharmacological agent that we can use, particularly for those who come with already have fractures there, particularly hip fractures. So thank you very much, Ronald.
Thank you,
And
JK.
yeah, so far there's no question posted here yet. So if allow, let me ask you one question. We know the drugs are there. We know the treatments are important. But how do we stir the interest, the confidence, the perception, and the mindset that as an orthopedic surgeon, we see the fractures, we are actually the best person to initiate treatment, to follow up treatment, to improve compliance and adherence. So how do you, as a surgeon, how do you actually convince our friends, our colleagues to do that?
So in my opinion, one of the most important things is that you have to start sort of educating your residents or trainees from the very beginning. So it's extremely important because once you have that sort of proper mindset and education, it just leads to sort of better improvements in the sort of the clinical care of your patients as the years come along. Because we found that if we don't sort of treat our patients' osteoporosis, there's a very high risk of imminent fracture. And we see patients that just come in again to our unit with another fragility fracture where we have to fix it again. And in fact, the mortality and morbidity rates is just much higher than even the first fracture. The second one is even worse than the first, in my opinion. So in based on this, it's actually very important to hold sort of regular meetings and also regular teachings, even I'd say back into medical school even. And also obviously these sort of international collaborations and international education is very important. Because these patients obviously come into the orthopedic settings at first sight.
Thanks, Ronald. Any question for the panel?
Yeah, can I ask a question?
Yeah, Rajesh.
Yes, yeah, Rajesh.
Yeah, Dr. Wong, great talk. I just want to put things in perspective, and my comment about teriparatide for hip fracture patients is I have got a few reservations about putting old people with hip fracture on teriparatide. One, just like we were told by Dr. Syed, 25% die in 1 year. So that would be even before they can complete their treatment. Second thing is the cost. Third is the compliance, particularly for an old person to have daily injections. And fourthly, like you very elegantly showed, that the teriparatide does not increase the density at the hip very much. We know that it's not very good at protecting hip fractures and not very good. So what do you think? Like my practice is all old people, if their kidney functions are good, calcium and vitamin D is adequate, PTH is not raised, and they are well hydrated, we would like to give them zoledronic acid because it's full compliance, 1 year, easy, affordable, and the cost is covered with hospitalization cost. You know, the patient's attendants, like out-of-pocket expense like we have in many countries, they are not burdened financially to buy the drug after the discharge. You know, they are often prepared to spend the money in the hospital, but they are reluctant to have out-of-pocket expenditure once discharged. So that's just my comment here.
Yeah, thank you, Professor Rajesh. I think that's an excellent sort of view as well. I agree that the teriparatide does not necessarily improve the sort of the hip that much. In fact, most of our patients at our unit use the sort of the intravenous zoledronic acid or the subcutaneous denosumab, and they follow up in our clinic. The only reason is because the anabolic drugs in a public setting, if they're covered, it's not that easy to be covered because we need a sort of a very low T-score, or they have to have 2 or more fractures. Obviously, the romosozumab is very promising, but they do have the we do have the concern in some patients that had a previous sort of stroke or MI. So we still need to sort of look into the side effects for some of the drugs as well. But definitely, thank you for your comment.
One short question from Syed and short answer from Ronald. Yes, Syed?
I was also asking that questions also. In our country, especially in Bangladesh, we don't have romosozumab. We have teriparatide. And the daily teriparatide intake by people is very much discouraged by their family members and the patients. This is a problem. So in case of trochanteric, I have a patient with intertrochanteric fracture, 107 years old. Will go for operation tomorrow. What is your suggestion for these patients? The patient is reluctant, unwilling to take this teriparatide available in our country.
Yeah, so I think if I heard correctly, so if the patient is not willing for sort of daily subcutaneous injections, we normally follow. Yeah, and if the patient's sort of kidney function is okay, we normally just follow up these patients either with zoledronic acid or denosumab. Because we do it in a sort of a specialized clinic. So we have a nurse coordinator that calls these patients and reminds them to come back. And once we sort of give the drug, 1 year later, we'll follow them up. For example, with the bisphosphonate, we follow up these patients every half year if they're using denosumab.
So as we know from the literature, from different literature, that then teriparatide has a very role in a union of intertrochanteric fractures. There is many study that there is early union of intertrochanteric fractures if you give them to teriparatide instead of giving zoledronic acids. In that situation, how denosumab will help these patients? This is not a anabolic group.
Sure. Yeah, thanks.
Denosumab and zoledronic acid combination. Do you suggest?
Ronald, you answer that?
Yeah, so for us, we normally go for the sort of the sequential treatment because as in our unit, we rarely or we don't really use combination treatment that much, although there is evidence, but in our center, we believe more in the sequential treatment.
Okay,
but thank
thanks.
you, Prof. Syed.
Thanks, Prof. Syed. Thanks, Ronald. And Prof. Syed mentioned actually from the beginning, 1/3 of vertebral fractures presented to us clinically. In fact, maybe even less. And vertebral fracture is one of the most neglected fractures, and many of them don't come in, don't get admitted, and many of them are walking on the street with severe hunchback. And all this is something that we have been neglected for a long time. And we talk about hip fractures and hip fractures and so on. In fact, vertebral fractures might be even more important in terms of management of the disease itself and also fragile fractures. So I'd like to introduce Professor Zairin from Indonesia, and he's going to talk to us about vertebral fragile fractures and particularly the prevention aspect. Yes, Prof. Zairin, the floor is yours.
Okay, thank you. Thank you, Mr. President. I start about prevention of vertebral fragility fracture, but actually this is not just about the spine, because this is very global hemostatic bone disease. This disclaimer, this is loss of body height may predict is osteoporosis in aging in the vertebral corpus fracture. Epidemiologic annual incident is around more than 10 per 1,000 women and also 5.7 per 1,000 men. This is orthogeriatric and perigeriatric, and also in the vertebral fracture, almost 16% happen in epidemiology. Fragility fracture is a broken bone, is a result of a minimal trauma due to, first is genetic aspect, dietary pattern a priority also, and so biologic effect, bone muscle with the osteoporosis, sarcopenia, and then become fragility fracture. These are bone composition. Bone composition about bone is inorganic is 70%. Each percent is water, and then organic is 22%. From organic 22%, the content about 50% is non-collagen, 85% is collagen. From the non-collagen, the content about the extracellular 85% and cellular protein is 15%. This appears about hydroxy crystal size. Crystal size bone normal about 24 nanometer, but in the market till now, no artificial bone graft is similar with the size crystal of the natural bone, still about less than 200 nanometer and more than 150 meter. This atomic mineral configuration hydroxy hepatic crystal from Indonesian population, this is my research 2011. In the normal bone, the calcium is just 8, but in the osteoporosis, the calcium atom is more than 10. That important information. And also in osteoporosis, in the substitution of on hydroxyapatite crystal, also in the Palette Regi 2008, and this is in my research about the group in the calcium, phosphate, hydroxyl can substitute with this atomic mineral, but the white one, this is still a question for the research hypothesis future. This one is the effect of substitution of bone density and porosity. But for the normal bone, whatever for the young generation with the good bone quality, we give anything about the mineral atomic, they will be useless. But the osteoporosis, they will give a response for the PB, strontium, that's good. But PB also with my college research, that also with the level quality, that's good also for the bone. In the osteoporosis, it's not important is high or low of the calcium. The important thing is how the distribution atomic mineral in the bone. If the atomic mineral in the bone is homogeneous, the quality of bone is good. But if the bone is the local mineralization, they make a group, the bone become not good. That means it's osteoporosis. This is also my research. For the normal bone, they follow pattern about modern periodic table model, but in the osteoporosis, the pattern is broken. They don't follow the modern periodic table period. This is the crystal atomic mineral configuration for nanostructure. They will make mesostructure also with the homogen, they'll be good. The mineralization local is not good, that means osteoporosis. And the meso, microstructure, and macrostructure, the bone quality, the good one is from crystal, become the normal bone. That not good in the crystal, they will become osteoporosis. How the effective management osteoporosis? Initial evaluation is from specialists, but long-term management become from GP. How the individual experience fragility fracture? Their presentation to general practitioner, medical center, or patient department also will direct to community-based And also they need hospital fragility fracture coordination. This post-acute inpatient rehabilitation also involved for the osteoporosis, also fragility fracture network. How the general practitioner, and also we don't have the community fragility fracture coordinator yet in Indonesia. Maybe we'll starting in the future how to make the operational product and manage the osteoporosis in our country. Preventing fragility spine fracture, back muscle strengthening is important, and also endurance, and maintain extension posture is important because the maintain bone density and post-fracture rehabilitation may reduce future fracture. And also exercise and diet, frequency is 3 or 5 days a week, resistant exercise 2 or 3 days a week, intensity, moderate intensity in terms of bone loading force, time may be enough is 30 to 60 minutes a day, and weight-bearing activity, example walking, climbing stairs, resistant exercise, weightlifting, adequate intake calcium and other atomic mineral. And also we must prevention about fall, discuss with family, medication, balance and strength training, correct vision, walking at, fall-proofing the home, fall lighting, throw rug, fat, and so on. And this is I writing about osteoporosis book in Indonesian language, but the other is from our group, Asia Pacific Orthopaedic Fragility Society. We have many books distributed. And take home message, physicians should understand the basic of science of bone before giving education about fragility fracture prevention. The problem of bone osteoporosis is start from characterization of hydroxyapatite crystal. Actually, it is not simple. For orthopedic, internal medicine, general practice to apply work of diagnosis as prevention fragility fracture for the osteoporosis population. Thank you, Mr. President.
Thank you, Prof. Zairin. Thanks for the lectures. And any question for the panel? So far, I have not received any question from the floor yet. Dr. Rajesh, any question on vertebral fractures?
No, I think it's all been so well detailed. The only remark I would like to make is that the incident fractures are very common in vertebrae. So which means that, you know, we should be on the lookout because the patient may not have a clinically evident vertebral fracture. So we should tell our radiologists that if they see any incident vertebral fracture, they need to be treated as well. And the same thing about the bone density. Whenever we are doing bone density, we are asking for VFA or the vertebral fracture assessment in a semi-quantitative way to also document, so that many times the patient will have enough compression on the vertebral fracture assessment to merit treatment. And that can be in terms of loss of loss of height or reduction of height itself would be an indication for starting treatment.
Okay, great. Any other comment? Might be Ronald.
Yeah, I thank you for the talk. It was great. I just wanted to ask, is it routine for your unit or or to the floor that a VFA is routinely performed for all your fragility fracture patients? This is for the floor and Zairin. Any sort of findings that you guys had with VFA? Was it a very high prevalence of vertebral fractures?
See, we know that the vertebrae are most commonly affected by osteoporosis. And we also know that almost only 1/3 of the fractures of the spine are actually clinically evident. So the point, it's a recommendation, not a protocol. But what I am trying to say is that particularly if a patient is complaining of loss of height or the deformity, and you are doing a bone density, it may be very relevant to do morphometry, because even if the patient does not turn out to be osteoporotic on the bone density, meaning that the density is below is above negative 2.5, it would still need treatment if there is significant reduction of the vertebral height. And second thing is then by that semi-quantitative classification by Genant, that's a good way to follow up, to know that whether the deformity at the compression has been increasing or not. So you can actually score them and then compare the score at a subsequent date.
Yeah.
And then
Sorry.
Yeah, Runner,
Yeah,
go
I
ahead,
think in my opinion, I agree. The VFA is important, because I think recently the sort of a paper published in OI also recommended that we can consider the use of sort of VFA for the fragility fracture patients, because sometimes we may possibly, as you say, that there are many sort of silent vertebral fractures.
Yeah, before I take question from Prof. Syed, for those who are not familiar with the DEXA role in the VFA, vertebral fracture assessment, your DEXA scan, you can actually do the routine lumbar spine and also the hip bone mineral density. But many machines actually allow us to do a vertebral fracture assessment where you're actually looking at T4 to L4. You either turn the patient to the side, do a lateral view, lateral scan, or sometimes the machine itself that patient do not need to turn. The machine itself, the C-arm will turn itself and actually do the scan for you. So you get the bone density on the lumbar spine, the hip, and the VFA, and without need to send the patient for a separate X-ray of the vertebra. So the DEXA scan actually allow you to do so. You can also follow up the VFA pictures over the next few years to identify or detect any presence of new fracture from there. That's something that your DEXA scanner can do for you. All right, for those who are not that familiar with DEXA scanner. Yes, question from Syed. You want to say something?
Yes, I was about to talking about this. There is a guideline for screening of osteoporosis. If we follow the guidelines, many patients coming to us for back pain, back problems, or other problems, especially the older patients and the older female patients. If we follow the guideline of screening of their patients, we can find that there may be osteoporosis. And if we advise them treatment, if we give them treatment, not only pharmacological treatments, including the therapeutics like physical treatments and pharmacological treatments, so we can prevent some vertebral fractures.
Thanks, Prof. Syed. Might be any input from Irewin? You want to say something?
We really have to, I think, in my opinion, really have to engage the different subspecialties, including the radiologists. We have to sort of include them in the management of hip fractures. Of fragility fractures, because in the screening, mostly patients with back pain, are just given X-rays of the spine. So if we include other subspecialties like the radiologists, in the education of care, so maybe we can detect more and prevent hip fractures.
Yeah. In fact, we emphasize a lot on hip fractures, and if vertebral fractures is actually equally important, is not more important. So you in fact detect them even earlier compared to hip fractures. So I think we cannot neglect or ignore the importance of fragility fracture involving the vertebra. All right? Yes. Thanks very much. And yes, Prof. Young, you say something.
Yes, it was a very nice talk. But I want to give a small comment. We usually focus on osteoporosis, but don't forget the possibility of bone tumor or bone metastasis. So like multiple myeloma or other bone metastasis also cause many labral or spine compression fracture. Because I'm also doing the bone orthopedic oncology, so I have a lot of patient experience about this. So please don't forget this kind of possibility when you treat the spine fracture patient.
Yeah. Absolutely. Thanks. Thanks
I'll
for
a quick comment, Dr. Lee, with your permission. A quick comment.
Yep.
I think that's a great point, and I thought we must elaborate on this. The secondary osteoporosis must be ruled out, and multiple myeloma is one of them, as many other causes. And one strategy could be to look at the Z-score. And if the Z-score is more than 1 standard deviation less than the T-score, you should really suspect a secondary osteoporosis, and you do that. So don't just look at the T-score. You must always look at the Z-score as well.
Sure. Thank you, Rajesh. Thank you very
much. Thank you, Yang, for pointed out this issue. Recently, I have a patient with vertebral osteoporosis. I diagnosed osteoporosis, but I take a biopsy. It gives to a secondary metastatic lesion.
Yeah.
So which is
Thanks,
really important.
Yeah. Zairin, allow you to say something.
Okay, thank you, Mr. President. In my clinical in Banjarmasin, Indonesia, if the patient comes with the spine deformity, usually ischiotic deformity for the eldest people, I did the long spine and then DEXA, and then I give the bone formation drug, and also I give I give zoledronic acid every year, and then I follow up every year for the patient like this.
Okay.
Thank you.
Thanks, Zairin. Thanks, Zairin. Okay. In terms of secondary fracture prevention, we all talk about this when to prevent the subsequent fractures after the initial fractures. And one of the things that we neglected is medical treatment, the underlying problem of osteoporosis. And one also very important component is actually prevention of fall. Because we know that most hip fractures happen following a fall. Although vertebral fractures, most of them don't have fall. They happen spontaneously. So fall management is very important. Fall prevention is a very important component for secondary fracture prevention. Therefore, we'd like to invite Rajesh to give his talk on fall prevention, balance, and all the other aspects on this. Yeah, Rajesh, the floor is yours, Rajesh.
Thank you very much. I want to thank the society and Lee in particular for this opportunity. And I think the stage has been set. What I'm going to talk about is the definition of balance and fall, the risk factors for fall, assessment tools to measure balance and predict fall, and prevention of fall. We know that the balance is the ability to maintain the line of gravity of the body within the base of support with minimum postural sway. And it is controlled by somatosensory inputs, visual inputs, vestibular inputs, which are actually then integrated centrally. And then there is muscle response, muscle strength, and range of motion. A fall is said to occur when an individual suddenly and unintentionally comes to rest on the ground or any lower level. And the recurrent fall is if you fall more than twice in 6 months. And then there is a near fall where a person slips, stumbles, or trips, but is able to regain control prior to falling. About 1/3 of people more than 65 years or more than half over 80 years of age fall every year. 1 out of 5 will need medical attention, and 1 out of 10 will sustain a fracture. And this is a leading cause of death. And of course, we know the statistics about the hip fractures. Now, in America, it is said that 1 out of 4 older Americans fall every year. So there's a fall every 20 minutes. 1 in 5 will lead to head injury or broken bones. And people who fall will have twice as much risk to fall again. And there's a tremendous cost. Why is fall important? Because it can lead to subdural hematoma, fracture, soft tissue injury, loss of function, mobility, independence, dignity, and confidence. And of course, there is a fear of another fall. And those who fall frequently have poorer outcomes. The worrying aspect is that the rate of fall associated with serious injuries is on the rise and maybe 100% higher by 2030. And as was said, in osteoporosis, the fracture occurs because of a combination of fragile bones and a fracture. And in this study, about half of the patients who were under treatment for osteoporosis had reduced physical activity because of a fracture along with caused by a fall. Now, why do we fall? Because there's a change in sensory system, motor system, and the central sensory integration leading to balance impairment. And there are multifactorial and interacting causes. Intrinsic risk factors are like gait and balance impairment, peripheral neuropathy, vestibular dysfunction, muscle weakness, vision impairment, medical illness, advanced age, impaired activities of daily living, postural hypotension or orthostatic hypotension, dementia, and drugs. There are extrinsic risk factors like environmental hazards, poor footwear and restraints. And there are precipitating causes like trips and slips, drop attacks, syncope, dizziness, and acute medical illness. And balance disorder is common in community, as was suggested by this study, where 1 out of 3 elderly people had a problem with the balance. There's also something called post-fall anxiety syndrome, which occurred in more than 50% of the patients who had a hip fracture. And that is particularly common in those who live alone, who have cognitive impairment, balance and mobility impairment, as well as history of fall. And you are more likely to have a fear of fall if you're obese and have impaired mobility. We all are conversant with the gait cycle. However, what happens is that the gait becomes abnormal with age. About 15% individuals older than 65 have gait disorders, which increases to 35% for those above 70 years. And with advancing age, more and more people need walking aids. You must distinguish between fallers versus non-fallers. So if you fall once, that doesn't label you as a faller. A non-faller has got a different gait pattern, and that you can distinguish, as is shown by these parameters, that the fallers have lower gait velocity and more variability of the steps, and they have a shorter stride as compared to non-fallers. So you can actually pick up those who are frequent fallers. This was also mentioned. The frailty is the decreased physiological reserve, decreased cognition, and decreased social function. And what happens is with age, with every stress, you are unable to come back to the same level of recovery as pre-morbid, and then eventually come to a state of dependence or disability. And sarcopenia was also mentioned by Dr. Wong. That is the age-associated loss of skeletal muscle mass and function. And that is diagnosed by a gait speed less than 1 meter per second and objectively measured low muscle mass using the DEXA. And that is, in men, it is less than 7.23 kilogram per meter square. And in women, it is 5.67 kilogram per meter square. You should suspect sarcopenia if somebody has normal gait speed, but low grip strength or low muscle mass, or if somebody has a low gait speed less than 0.8 meter per second and low muscle mass, then he is sarcopenic. Sarcopenia, along with physical frailty, is a part of general frailty, and which includes the cognition and other domains, and is responsible for fall, as was shown by this study among 847 Mexican Americans. So how do you evaluate them? You inquire about any fall on difficulties with balance and gait. It's a multifactorial assessment, identification of risk factors, and targeted intervention. This book I wrote for Indian Society of Bone and Mineral Research. And in that, it's a simple list about who is prone to fall. Those who have poor eyesight, those who have fallen previously, cannot stand on one leg, take long time to get up from the chair and walk, trip often or collide, take medicines which make you drowsy, have postural hypotension, which means blood pressure falls by more than 20 millimeter of mercury or falls below 90 millimeter of mercury on standing from lying position, and emotional or state of mind also contributes to the fall. And accordingly, we have advised one self-assessment to assess the balance. And one interesting thing about that is, which was described by Tinetti, is stops when he talks. So if a person is unable to keep on talking while walking, he's at high risk of fall. When you take a history for fall assessment, it must look into circumstance, the frequency, time, location, circumstances, surface, and obstacles, associated factors such as footwear, walking aids, glasses, substance, drugs, etc., associated symptoms like dizziness, vertigo, tinnitus, legs giving away, chronic problems like cardiovascular diseases, neurological diseases, the past history of falls, new symptoms. The drug history is extremely important because polypharmacy is a very important cause of fall. And then diuretics, analgesics, and alpha blockers, or those which are causing sedation also predisposed to fall. And then, of course, you should ask about the functional status, whether the patient was ambulatory, indoor, outdoor, or without the support. The physical examination includes the sensory examination, cardiovascular examination, neurological, musculoskeletal, mobility evaluation, and assessment of balance and gait. The environment assessment is an important part. You must look at the lighting, walking surface, furniture, railing, clothing, equipment, etc. Mental and affective testing, as well as lab and diagnostic testing for anemia, electrolyte imbalance, dehydration, arrhythmia, screening for osteoporosis, blood count, X-ray, and ECG. So this is the ABC of why older agents fall. That is age, ambulatory status, and assisted device use, balance, behavior at the time of fall, chronic conditions, cognitive defects, drugs, exercise level and environment, footwear, and flooring. And if you have greater number of risk factors, your risk of fall becomes greater. This is a very important test, which is called 30-second stair test. If you hold your hands across your chest and get up from the chair, you should be able to do it at least 14 times in 30 seconds. And if you have a below average score, it indicates a risk for fall. Another test is the functional reach test. You stand with your feet shoulder distance apart, and then you try to reach out without losing your balance or without swaying. And if you are not able to reach 7 inches, that is highly predictive of falls in older people. Another very important test is the floor transfer test, moving from standing to sitting on a floor mat or back to standing. It's measured in seconds. Then there are special clinical tests like timed up and go test, Berg balance scale, performance-oriented mobility assessment, clinical tests of sensory integration for balance. And this is a timed up and go test, which is actually one of the most useful and easy to do tests. The patient are asked to get up from the chair, walk for 3 meters, make a 180-degree turn, return to chair and sit down, and they are allowed to use their walking aid. It is normal if they can do it within 10 seconds, abnormal if they take more than 14 seconds, and if they take more than 20 seconds, they have severe gait impairment, and that's a very sensitive and specific test. Berg balance test looks at the balance between the sitting position, standing position, and the dynamic balance. And in this list of all the tests which can be done, you will realize that the Berg balance test and the timed up and go test are highly sensitive and specific and can be routinely employed. We have this Balance Master, which is an equipment which is able to assess fall risk, postural stability, clinical sensory integration, balance testing, and balance training also. So you have these footprints where you're supposed to stand, and then this is able to rock in different directions, measure the pressure which the foot is exerting onto the platform, and give readings. And then we have a gait lab, which is actually also able to capture the gait pattern. So you can look at the step length, stride length, etc. The most important thing is that if you have instituted some intervention, like some exercises and all, it can objectively tell you whether the patient's gait is improving or not, and actually can help you for a very good feedback or validation of your intervention. Fall prevention is extremely important. Falls are highly preventable. We can do a lot to prevent it. This is mostly multifactorial intervention which involves strength and balance training, home hazard assessment and intervention, vision assessment and referral, medication review, and the exercise interventions are mainly the strengthening, endurance, and flexibility exercises. And if you can strengthen the lower limb and core muscles in 2 to 3 sets of 10 to 12 reps of each muscle group, that on twice a week on non-consecutive days. And similarly, the flexibility exercises can also be recommended twice a week. So these are some of the exercises to reduce your risk of falling. You can do this with the support of chair, and then you can also do them by putting pillows under the feet, and then you can use the physio ball. The balance exercises have been recommended by Mayo Clinic as well. The yoga helps you maintain your balance. Tai Chi is a very useful thing. There can be task-oriented motor learning exercises like stepping forward and across, walking, at a certain speed, and then changing directions while walking an oval path and all. So this is an example which we use in our sitting. You can ask the patient to move along those tracks and while maintaining the balance in order to improve their balance. And it has been shown that these programs reduce the number of falls, and this is the best technique. And exercises which work best are those which challenge the balance, use higher dose of exercise, and walking is not really a great exercise for preventing fall. The assistive devices are extremely useful. They actually broaden the base of the support. And if your patient is at a high risk of fall, it is better to advise them assistive devices. There are these walking sticks available with alarm if in case there's an irregular surface there, and the hip protector, one of which has been designed by us, which can prevent a fracture after the fall. There are cutting edge concepts and practice available. There are new technologies and computer assisted balance boards and posturography, virtual reality, and some games and balance whiz, which can help prevent the falls. This is an example of balance training by Biodex, which allows weight training, postural stability training, maze control training, and random control training. So this is a typical screen where you can show that how much load the patient is putting on each side, and he can be trained to shift the weight, and that way he can actually keep on improving his balance. This is a maze control training where the patient can shift his balance to actually hit the targets sequentially one by one, learns to control his body better and get better results. And then of course there's random control training like this. There are games which are called exer games, which are exercise based video games. They can improve the physical balance and strength and cognitive function, and then they are available by V also. There's something called volitional step training, which involves rapid and accurate steps in multiple directions, which can reduce falls by 50%. There's another step you can see, there is a support or harness for the patient. The patient is exposed to repeated slips or trips to generate rapid balance response, and it also reduces the falls by 48%. We started this facility. This is a newspaper cutting in the local language, but this is called Sathi, S-A-T-H-I. Sathi means a companion in our local language, but it is a Save the Hip initiative. And there we have this balance master and all these wobble board exercises and the trampoline exercises. We know there are certain drug interventions which can help, like vitamin D, the deficiency of which gives rise to reduced muscle mass, weakness, slow reaction time, and increased risk of falling. And we know that the monthly dose of vitamin D can prevent fall. Myostatin antibody, which myostatin inhibits skeletal muscle growth. So myostatin antibody has been shown to increase lean mass and improve the muscle power. Similarly, single dose of methylphenidate has been shown to have better postural stability. In patients with Parkinson's disease, reverse stigmine has been used for the balance testing. Of course, you have to spot the hazards. Yeah, as was told by the previous speaker, you should remove all loose rug and loose cables. You do a brown bag review, look at what medicines the patient is taking and take out the unnecessary medicine. Have vision and hearing examination every year. Keep everything within reach so that the patient doesn't have to extend too far up and too far low. And of course, give them walking support, particularly if a patient feels orthostatic hypotension, which means get head rushes when these stands too quickly. Teach them to rise slowly and count up to 5. No loose rugs, no loose wires. The steps should be safe and adequately lit, and there should be a railing, and there should be all attempts to prevent fall. The clothes and slippers should be friendly and not make you fall. And then bathroom is a big offender. Add grab rails to shower walls, use a bath chair and handheld shower, and use non-slip tub mats. And there are certain community-based programs which essentially mean add screening tools, perform balance exercises, give adequate vitamin D at community level, strengthen the muscle, cognitive behavioral training, educational sessions, popularize hip protectors, and identify people who are at risk of osteoporosis and advise them on fall prevention and promote a healthy and active lifestyle. So to conclude, falls are common in elderly and may lead to injuries and decline in function. Evaluation should include the risk factor assessment, balance and gait assessment, and of course the home assessment also. Exercises improve the outcomes. Injury prevention is an important goal in the population, and your treatment must be individualized. Thank you very much for your attention.
Thank you very much, Rajesh. And it's a really, really important message there. And I really doubt you're orthopedic surgeon or are you geriatrician actually? And beautiful talk. Okay, you cover all different aspects, emphasize all the important point in different aspects, and I'm sure all the audience actually learned a lot from your lectures for the past 15 minutes. Excellent. And any question from the floor?
But I only comment I like to make, Lee, is that every speaker before me has touched upon these. Even Professor Zairin had talked about, not having the loose rugs and not having loose wires. I think there are a lot of interventions required in the patient's own environment. And one thing I often tell patients is, of course, now the time for landline are gone, but I used to tell them have a hands-free phone and keep it with you so that you don't run if there's a call. Now I tell them keep your mobile phone with you or cell phone with you, so that an old person who's living alone will rush if there's any phone call because they would like to take that call. That has been called as impulsivity in the various instruments for assessing the risk of fall. So I think we need to do a lot. But you wanted to ask something. Is that
now? Really, I hope that all orthopedic colleagues, surgeons, and who are interested in osteoporosis and fragile fractures, which we are supposed to be, we really learn from you, and also want you to share your passion about not only orthopedic practices but also on osteoporosis, fragile fractures, balance, fall prevention as an orthopedic surgeon. In fact, as I say, orthopedic surgeons should be actually playing a leading role in all these different aspects. So I really enjoyed the talk. You really learned a lot from the beautiful talk that you had for us. Okay. Yeah, thanks, Rajesh. I think without further ado, allow me to introduce the next speakers. Tabu is a very young man that I met a few years ago in the Fragility Fracture Network meeting. And since then, I can see that he actually has done a lot and he has developed a lot of programs, not only for Philippines, but for the regions and globally. And he is one of the key person who playing a very important role in the regional, or we call regionalization of Fragility Fracture Network. And we are honored to have him in our council. And also we are honored to have him as a speaker today. And he will talk about promoting Orthogeriatric. Most likely he will talk about share with us the experience if you have a geriatrician, or what if you do not have a geriatrician, how to promote orthogeriatric care for our patient come to us with fragile fractures. Irewin, the floor is yours.
Thanks, Mr. President, for the very kind introduction. First of all, I would the first four speakers, Prof. Syed, Rajesh, Prof. Zairin, Noor, and Ronald for the wonderful talks. Okay, so in the next 15 minutes, I'll be talking about orthogeriatric care in the Asia Pacific region. I have no financial conflicts related to this talk, although I have to give the acknowledgements to the due persons. And this will be the outline of my presentation. I'll be talking about fragility fractures in the aging population. Give the reasons why the treatment of patients with fragility fracture goes beyond the fracture fixation, and identify the extended role of orthopedic surgeons within the orthogeriatric management, which I think we've been mentioning during the last 1.5 hours. And lastly, I want to say about the global call to promoting orthogeriatric care amidst the challenges, and relate some of our own local experience. So much has been said regarding the burden of osteoporosis and fragility fracture. I just want to reiterate that like 3 years ago, in a sub-study based on the International Orthopedic Multicenter Fragility Fracture Study, among female patients, the most significant source of fracture burden in the elderly was to be fragility fractures, such as hip fractures. And in this study, it included low to middle income countries, which included countries in the Asia Pacific region. Okay. During the time of the pandemic last year, okay, a study was published from India citing that fragility hip fractures or hip fractures in the elderly actually has been coined as a pandemic within a pandemic, and that a multidisciplinary approach should be rendered for these patients in order to improve the overall outcome to survival. And a very popular slide is the old age dependency. It says that there will be a tremendous increase in the number of older patients in the next 30 years. So the challenge for the hospitals and physicians and orthopedic surgeons in the Asia Pacific region is how do we deal with the exponential fragility fracture numbers? No, given the change in the demographic structure, workers to support the elderly people, since most are diverted to take care of COVID patients. We will need more efficient prevention of fragility fractures, more efficient treatment in order for these patients or the older patients to have better return of function and for them to have retention of independence if they suffer a fracture. Okay, so the problem actually lies in that older patients, in dealing with older patients with fragility fractures, we are faced with two problems. And we are more familiar with the biomechanical problem only, or as orthopedic surgeons, which is the fragility of the bone. But the equally important thing is the frailty of the older individual, which is a physiological problem. Frailty actually is a common syndrome in older people consisting of physiologic aging, which means that they cannot tolerate common stressors such as injury coming from a fracture. There's the problem of muscle weakness, sarcopenia, cognitive dysfunction, which belies these patients, and also the frequencies. Nowadays, there's the term called osteosarcopenia, which we should address. Okay, so now, given all these facts, us orthopedic surgeons should know not only to manage the fragility, but also how to address the frailty. And with this challenge, we have to sort of collaborate with other subspecialties like a geriatrician, because the patients, our patients with fragility fractures needs both skill sets. And of course, the multidisciplinary team is bigger than that. It will include anesthesiologists, the nurses, the rehab medicine, physiotherapists, even the caregivers and the family members should be included in the team. But the key is having this orthogeriatric combination. Okay, so geriatric medicine is actually the branch of medicine that specializes in frailty. However, other physicians, most especially in physicians and family medicine physicians, can really acquire geriatric competencies. And the co-management by orthopedics plus geriatrics is what we call orthogeriatrics. And it has been found to lead to better outcomes in patients with fragility fracture, shorter length of stay in the hospitals, and it leads to reduction in complications and readmissions. Okay, so orthogeriatric co-management has a very potential for improvement in terms of shorter length of stay in the hospital, lower complications, readmissions, better restoration of quality of life, and most of all, especially now that economies of countries are really stretched out, providing cost-effective care due to cost reductions. And in these patients, the geriatric co-management principles can really be spearheaded by an orthopedic surgeon. Orthopedic surgeons should be leading the team approach from admission until the completion of the rehabilitation, and should not only be focusing on fixation itself. We need interdisciplinary care. We need co-ownership. We have to share the responsibilities in caring for these patients with fragility fractures, and be emphasizing on pathways of care, protocol-driven care, all the members of the team rendering care to these patients with fragility fractures. The prioritizing the patients, because elderly patients are like pediatric patients. They have many problems. Their immune systems are not that optimal, of course, and they have aging. Okay, so when we talk about orthogeriatrics, we are talking about quality standards embedded in the pathway of care of orthogeriatric co-management. And some of these quality standards are acute fracture care or acute surgery for these fractures, ideally within 24 to 48 hours, a joint care and orthopedics, no? A collaboration of the geriatricians and the orthopedic surgeon, a good pathway of care or assessment protocol, okay? A geriatrician and a multidisciplinary rehabilitation centered on early mobilization, weight bearing of these patients. Of course, fracture preventions, falls prevention, and also the recognition of pre and post-op delirium. Okay, so knowing all of this, no, in this next three graphs, which are only actually these are raw data, no, and from the FRMAT or the Fracture Care Mapping Survey Project, which the University of Oxford has run 2 years ago, we can see that among representative countries in the region, no, for which this survey was rolled out, okay, there's still many hospitals and institutions wherein the timing from admission to surgery is beyond 2 days. Okay, most many hospitals have been rendering care, surgical care for these patients actually for 5 days. Okay, and a very important aspect of this management, many patients, no, are still not brought to the hospital within 24 hours. In fact, a number of patients seek hospital treatment, no, still beyond 3 days, and some beyond 5 to 9 days. So we really render orthogeriatric care to these patients if the issue of bringing elderly patients to the hospitals, no, because of fear of surgical treatment for these patients, really hounds the family of these patients. Okay? So in this survey, it was also shown that among hospitals, no, among representative countries in the Asia Pacific region, there are very few geriatricians. In fact, orthogeriatric care there's a difficulty in rendering orthogeriatric due to the lack of geriatricians. Okay, so we will tackle how can we roll out orthogeriatric co-management even with the scarcity of geriatrics in our institutions. So in all of this, what is the role of orthopedic surgeon? Say, I'm not biased, but I'm just saying this, that orthopedic surgeons can really act as standard bearers of the multidisciplinary team. No, why? Because we are really the gatekeepers. We are the initial patient contact. We see these patients with fragility fractures. Therefore, we have the responsibility of initiating the team approach because nobody else will do this. The responsibility for a better outcome is really one of the responsibilities of an orthopedic surgeon. And it should not be an excuse if hospital or our country is lacking in geriatricians, because in low resource settings, geriatric competencies or the ability to manage frailty can be taught to other physicians, nurses, and other healthcare workers. Okay, so in 2018, the Fragility Fracture Network released this call to action to promote orthogeriatric care. Now, this was supported by many international organizations, including the IOF. In fact, one of the supporters or one of the regional supporters of this call to action is the Asia Pacific Orthopedic Association. Okay, and the call to action is hinged on the 4 pillars of the namely acute multidisciplinary care, rehabilitation, and secondary fracture prevention, which comprises the first 3 clinical pillars. And an important aspect is 4th pillar, which is a political pillar, which is the establishment of multidisciplinary national alliances. We believe in order to convert the call to action into actual action, multidisciplinary should be formed in countries, and these alliances should imbibe and should promote orthogeriatric care. So even if there are very few geriatricians available, geriatric competencies and the ability to manage frailty can be taught to other physicians, and we empower our nurses, because they can be our extension in providing orthogeriatric care. And thus, because of this challenge, the Education Committee of the Fragility Fracture Network is designing a web-based course, based on 2 existing assets, which may help you if you want to promote orthogeriatric care in your country. The first, I think this book was already mentioned by Professor Noor. Okay, The first is Orthogeriatric book, second edition, which really gives the details about 4 pillars of the call to action. This was published in 2020 and has been translated to many languages already, such as the Spanish, Greek, Arabic, Mandarin, Russian, Hindi, and Marathi. So this will be a very useful educational tool if you want to promote orthogeriatric care in your country. The second source material will be the clinical and policy toolkits, which was also a project by the Fragility Fracture Network. In here, as I mentioned earlier, you will be given per each pillar. You will see how the pillars can be carried out. Giving all the necessary resources and the information in order to carry out these pillars. And in the next few slides, I would like to just give experience in the Philippines. Since we rolled out the orthogeriatric care co-management institution, we had a decrease in time from admission to surgery from 12 days to 5 days, a decrease in the length of the hospital stay from 19 days to 10 days. And of course, there was a 72% increase a management of osteoporosis in patients having fragility fractures. And nowadays, because we saw this importance, we are rolling out this newly approved program in which we will be having a multi-center implementation of orthogeriatrics in the fracture liaison service for elderly hip fractures in 14 public institutions in the Philippines, in order to expand orthogeriatric care and FLS in the Philippines, supported by a hip fracture registry. So hopefully, this will also help the other institutions, not only the university institutions in our country. Okay. Important project is the Global Orthogeriatric Survey, the FFN Global Project, which aims to map the availability of orthogeriatric co-management existing globally. This is sort of analogous to the Capture the Fracture campaign of the IOF for the Fracture Liaison Service. The goal is to chart progress, identify obstacles, educational and policy needs, informing country-specific work regarding orthogeriatrics. And the goal is to have the national FFNs catalyze the collaboration with the educational committee FFN in order to promote orthogeriatric care in specific countries. And the regional meetings of the Fragility Fracture Network in 2022 will focus on this care development. So in summary, the prevailing health condition and population aging is driving fragility fractures. Therefore, there's really need for multidisciplinary orthogeriatric to improve outcomes and to provide cost-effective care for these patients. Orthogeriatric care can be implemented even in non-ideal or low-resource settings. So if you have lacking in geriatricians in your country, you can still pediatric care. Okay, orthopedic surgeons should change the culture and should take up the challenge extended role as the standard bearers of the orthogeriatric care multidisciplinary team. And the Fragility Fracture Network is pooling our worldwide experience of acute management and secondary fracture prevention to promote orthogeriatric care through national FFNs and hopefully through the Global Orthogeriatric Care Project. So thank you to my talk. And if you're interested in establishing a national FFN and promoting orthogeriatric care in your country, feel free to give me an email, a personal email. Maybe we can help you establish a national country in order to support your orthogeriatric care services. So thank you and hope you learned something from my presentation.
Thanks, Irewin. Thank you very much for the excellent talk. I like the statement, pandemic within a pandemic. And it's true, all right? And we do see increase in the incident of osteoporosis and fragile fractures in all countries in this region, particularly Asia Pacific. And really it's time for us to act. In terms of the old age dependency ratio, it's also increased from the year about 2020 now in many, many countries in this region. So thanks for highlighting the importance of this pandemic within a pandemic, and so the importance of orthogeriatric the role of Orthogeriatric in our fragility fracture care. Thanks a lot. And
Thank you.
the floor is open for discussion, all of us. Yes, you can unmute, all of you, and feel free, open for your discussion.
Thank you, Mr. J.K. Lee, for
Syed.
under your leadership for an excellent and wonderful webinar organized by Asia Pacific Osteoporosis and Fragility Fracture Society. So you from your last word, the fragility fractures, osteoporosis and fragility fractures is also a pandemic. You said like that. So, and we have to give attention to this pandemic also in addition to pandemic COVID-19.
Sure.
It is very important. We have to develop awareness among the general populations, among the healthcare professionals, as well as the persons who are involved in the management of the country, that is politicians and its governments. So if we work together, especially in Asia Pacific regions, I told in my lecture that there is a scarcity of data, especially like from Bangladesh. We have no authentic data regarding the osteoporosis and fragility fractures in our country. There are many countries like that, and especially the country like India, where Rajesh is working for many years, and China, they have a huge number of populations, and 60% of populations lives in the rural area. They don't have the facilities of diagnosis or screening programs. So already there are many screening programs for breast cancers, but the mortality rate and the incidence of breast cancer is less than fragility fractures and osteoporosis. So we have to give this importance. We have to convey our message to the concerned authorities.
Thanks for the input, Syed. And let me go through. Ronald, any comment, any input?
Yeah, thank you, JK, and thank you, APOFFS, for this great webinar. I think it's very important as a orthopedic surgeon that we don't only fix fractures. So we should definitely also focus on the sort of the post-op and aftercare rehabilitation for all our patients. That includes osteoporosis, and that also includes the sort of orthogeriatric care and the sort of the fall prevention, which was given by the sort of the lectures by other speakers today as well.
Yeah. Thanks, Ronald. Zairin?
Yeah, thank you, Mr. President. This is important for us from the APOFFS, is broadening our minds. Also, like me, as a spine surgeon, I learned now about the orthogeriatric from Irewin Tabu also. And then thank you for this, Dato, and then coordinating this APOFFS. Thank you, Dato.
Thanks, Zairin. And Wu from Singapore.
I must say, thanks, JK. I must say, today's webinar is really, really fruitful. All our speakers actually brought me to see things in a much more different perspective. And fragility fracture is really important because, I mean, I myself come from a big department. My department is now around about 45 orthopedic surgeons. And because, I mean, there are only a handful of trauma surgeons, but there are quite a number of people who are fixing, geriatric fractures like hip fractures. And sometimes when some of the patients, they pass it to me to manage, and I notice the awareness about geriatric orthopedic and also fragility fracture is extremely bad, in the sense that not that many people do follow up on this. So I think today's webinar is very good. It's extremely important because it really gives me a perspective and an idea how can I help to make my colleagues more understand about fragility fractures, which in promoting them to look into this a lot more than just orthopedic surgeon fix a fracture and send the patient home. Right.
Thanks a lot.
Thank you very much. Thanks for the effort. Thank you.
Thanks. And Dr. Yang from Taiwan.
Yes, in Taiwan, in our hospital, we have also geriatric practice. Actually, Derek, as the JK, your best friend, Derek, you know that, you know him. He is a geriatrician, and he's responsible for our department of geriatrician in our hospital. So we collaborate very well. And actually, in our department, we also incorporate the PT. They come to our ward every day, and we can ask them to help us to the process of rehabilitation very well. So in our practice is okay, but in Taiwan, maybe we have to promote more practice in our hospital. That's all.
Sure.
Thank you.
Thanks, Yang. And how about Dr. Bulan?
Yes, JK, it's excellent presentations. Now, what I feel is there's one thing, what I feel is these webinars are very useful, and we know the essence of actually all these fragility fractures. But the fact is we got most of the data from Europe and America, but we need more data in the South Asia Pacific regions and South, Asian regions. And there's a lot of difficulties in getting data from Asian regions because most of the population, they live in the rural areas and they approach the rural areas, less amount of hospitals in rural areas, and more of a general hospital in the rural areas. So most of the fragility fractures, they are pushed to general hospitals and they do not know about the gravity of fragility fractures. So what I think is we need more data in our regions, and we need, it's a high time now, we have a separate geriatric ortho hospitals, like specialized hospitals where you can give care like the special kind of treatment. We do not treat those patients as fragility fractures as those treated in the younger patients. And we need not only those, but we need to go for medical treatment and rehabilitation and so on. So I think we have to emphasize, I think, more on our reason, getting those data from the Europe and Americas, but we also have to have our own settings and own setups in our region too.
Sure. Yep.
Thank you.
Thanks, Bulan. Bulan is from Nepal. And Dr. Rajesh?
Yeah, thanks, Lee. I think I would like to make a few editorial comments. One is that we must be aware of our regional and local national situation. For example, we have rampant vitamin D deficiency, so we must take care of that in every patient who comes to the outpatient. Advising oral vitamin D in the maintenance dose is the least which you can do. The second thing is, the impressing upon the patient the need, the awareness. We talked a lot about the awareness, and awareness has to start from each one of us. So when we see a patient, I do ask her if she is around 50 and coming for knee replacement. I ask whether you are still menstruating or not, or if a patient is at high risk for the age of menarche and the age of menopause, and more important, the family history. Any patient who comes with a fragility fracture, say the wrist fracture, Colles fracture, we do ask whether there's a family history, and we impress upon them that if there's a family history, you are at a higher risk. Same way, no patient of hip fracture leaves the hospital without definitive treatment, say either in terms of zoledronic acid, or if the kidney function is not very good, then the denosumab. So that is our duty. We can actually start the fracture liaison services with our own, even our own practice also. Let at least not any patient go away from me without getting treatment for the osteoporosis. And lastly, like Dr. Yan said, we are having a National Center for Aging, which is by Government of India. It's a premier institute. They gave us a National Center of Aging. So I told the chairman of that center that I will not fix the fracture on a patient after admitting under me. So you admit the patient in National Center for Aging, you work up, you stabilize, you make the patient fit. I'll come, give me operation theater and 10 beds. And I'll come to your center, fix the fracture, make the patient stand and walk, and you make sure that his blood pressure, heart, lungs, everything, kidney, everything remains optimum. So now, once I ask for an operation theater, they have actually made 2. So they say one is for orthopedic surgeons for knee replacement or the fragility fracture fixation for the admitted patient. The second one, I hope you can guess, is for urology, for prostate and for those. So they have made another theater for general surgical thing, especially keeping the old age degenerative problems in mind. But I think the society has been doing a great job. We need to push on. And of course, I took over as the chief of trauma center 5 years back in 2017. And the first thing I did was I earmarked 8 beds for orthogeriatrics. And I told my geriatrician that you have to look after these 8 patients. Because they are the patients who need either an echo for some evaluation or something. Although we are coming more and more out with such guidelines as to you don't need a preoperative echo, you don't need anything to be worked up before fixing the fracture, because that is what is the priority. But I think between us, I think given the vast experience of all the participants and members, I think we can make a difference. That's my conviction. And thank you very much
Rajesh.
again for
Thank
the
you.
opportunity. Yeah.
Thank you. Irewin.
I just want to repeat what Ronald mentioned earlier regarding educating our registrars, our residents. I think we should extend this education even to the medical students and interns. No, I must say I'm also guilty. No, I was just like the common orthopedic surgeon, wherein I would just be focused on fixing the fracture. But upon learning that, the concept of pediatrics, fragility fractures, and everything, I felt that I had to give more and I had to learn more. And nowadays, when med rotate in our department, we teach them not all the orthopedic stuff, to be primary care doctors, focusing on how to take care of the patient, that orthogeriatric care can be rendered, even in countries without geriatricians, because if you teach the students, if you start from the grassroots and teach the students about orthogeriatric care, then they will have the orthogeriatric competencies in them, so that 5 years from now, it will be easier to promote and to carry out orthogeriatric care for patients with fragility fractures. That's all.
Now, Asia Pacific Osteoporosis Fragility Fractures, as you mentioned earlier from the beginning, is a new section under APOA, and it was actually approved last year. And we really hope that the passions that we show from all the council members, in fact, we have council members from many countries, including Bangladesh, Malaysia, Singapore, and Philippines, India, Hong Kong, and Indonesia, Taiwan, and Brunei, Australia, and Nepal. And so all of us in different countries here, and we form the council member so that we want to bring this passion and also this importance of fragility fracture care and osteoporosis to everyone back home in our own country. And one of the best platforms is through our APO, FFS, and APOA. We really want to stir the awareness. We want to stir the interest that orthopedic surgeons should play a leading role in all different aspects of osteoporosis, fragility fractures, fracture liaison service, hip fracture registry, and not only fixing the fracture itself. It's much more that we need to do, that we can do, and we should do. And hopefully with the spirit from all the family members, APO, FFS, we can actually encourage you to join us, our society, our section under APOA, as an active member to participate and to fight osteoporosis and fragility fractures in this region and for all our countries, our people. And so with that, I hope that any other remarks? If not, it's time for us to close the session. Yes, Syed?
Yes, Dr. Lee, do you want to say something about the approval of our proposal by Asia Pacific Orthopedic Associations?
Yeah,
Regarding the study?
the survey. Yes, we're actually doing a survey and to all APOM members and about the perception and the view of managing osteoporosis and fragility fractures during the launch, most likely early next month. combination is the effort between APOFFS and also the Asia Pacific Fragility Fracture Alliance, APFFA, in which you have 7 different global international organizations with us in APFFA. So this has been approved by the Council of APOA, so we will be free to actually kickstart the study very soon. And we hope that we get the support from all APOA members, fill out the survey, and tell us how you feel, what are perceptions about your practice in terms of fragility fractures and osteoporosis. And so thanks, Syed, and thanks to all the audience, and thanks to all the speakers for the support, the passion that you show, the excellent talk, the beautiful talk from every one of you. And of course, not to forget Dr. Ashok and the team for supporting us on OrthoTV and even view on the YouTube and Facebook. We hope we'll meet you again very soon to talk about all different other aspects on osteoporosis and fragility fracture care as well. Please join us as a member APOFFS and join us in the effort to fight osteoporosis and fragility fractures. Thank you very much, all of you. Thank you. Have a good evening.
Thank you very much.
Thank you.
Thanks.
Yeah. Thank you so
Mr.
much.
Thank
Syed.
you.